Hi everyone. 18 emergency room visits in less than 2 years, 8 bathroom wake-ups each night, 3 bladder-specific medications, multiple consults with various medical specialists, years of chronic urinary tract infections, and every single day dictated by proximity to a bathroom. Hi, I'm Naomi, and I'm a physician working in women's health for over 2 decades. This story is one of my patients who has graciously agreed to share her experience. She's 65 years old, and when she first came to see me, she was frustrated, suffering, and grieving years lost to the debilitating impact of this often minimized ailment. Today, she's not had a urinary tract infection in months. She no longer needs antibiotics, and she is off all her other bladder medications. After years of struggling, she finally has her life back. What changed? She started using vaginal estrogen, a Health Canada approved medication which provides a small amount of a hormone her body stopped making at menopause. Vaginal hormones are safe, they are effective, and they are available in a generic medication costing as little as $10 per month. 80% of women will experience bladder and genital symptoms after menopause, just like my patient. A 2024 study published in the Urology Practice Journal found that simply putting women on vaginal estrogen has the potential to save U.S. Medicare $6 to $22 billion per year. Why? Why, despite having this simple, effective, and cost-saving solution in pharmacies in every city across this country, did it take this woman so long to get what she needed? I'm going to tell you why. Because we have not educated our doctors about mature women's health, and we have not empowered women to understand their health needs. To be clear, this talk is not a big pharma endorsement, nor a plug for vaginal estrogen. I chose this example as a way to illustrate that we already have feasible solutions at our fingertips. What's needed now is education and advocacy to put these solutions into action. And I want to urge women that when it comes to your health, it starts with you. I also want to make a passionate plea for female sex-specific healthcare that accounts for the differences in anatomy and disease presentation in men and women. Early in medical school, I learned that babies and children are not little adults. Their developing bodies and brains are different. The same applies to women. Women are not small men, yet the default human body for science and medicine has been taken to be the male body. A quick word about language. I will be using the term women to refer to individuals with vulvas. I respect not all people with vulvas identify as women. There are pivotal inflection points in our health trajectory over our lifetime. In infancy, physician well baby checks assess growth and development every 2 to 3 months. The 18-month baby check provides an especially comprehensive evaluation to screen for language delays and autism, because we know early intervention is vital to health outcomes. At puberty, checkups are tailored to focus on substance use, periods, and providing education on contraception. When we get pregnant in our culture, we celebrate this. We make sure women know what to expect when they are expecting. As a doctor, the journey through pregnancy has delineated milestones assessed at each visit, including, among others, blood pressure, weight, and listening to that oh so beautiful sound of a fetal heartbeat. You cannot graduate medical school without knowing these basic aspects of caring for patients. But somehow, this all stops at exactly the same time women can no longer reproduce. At menopause, we monitor women meticulously while they are populating the world. Then, at a critically vulnerable time in their lives, we drop them. The cultural education on what is happening to women's bodies, the education of physicians to understand mature women's bodies, and the health checkups all stop. Suddenly, health checkups are few and far between, and when they do occur, they are short and generic. A typical midlife physician checkup is 20 minutes. Height, weight, a cursory physical exam, a few cancer screenings, and maybe, just maybe, a little bit of blood work. 20 minutes for this decisive life transition, this opportunity to change the trajectory of a woman's life as she moves from the first half to the final half. Midlife is the juncture where women's health risks increase dramatically, and most women begin this transition in their 40s. A quick note on perimenopause. Perimenopause is the 5 to 10 years before a woman stops menstruating. During this time, hormones are erratic, and this causes a plethora of symptoms. Menopause is defined as 1 year without a period. Typically, this happens at 51 years. Every woman will have a different journey through perimenopause. In my early career, I was puzzled by these high-functioning women who came into my office suddenly troubled with a cornucopia of symptoms: low mood, anxiety, poor sleep, relationship difficulties, requests for memory tests, high cholesterol, and weight gain. There was a long list. My 1 hour of training on menopause in medical school had not prepared me for this. Yes, 1 hour of medical training for a critical 10-year stretch which impacts every woman and may well be the most vulnerable health decade she'll ever encounter. I was not left unscathed by menopause. When I entered my late 40s, I suddenly didn't feel quite right. I didn't experience the classic hot flash breaking out in an uncontrollable sweat. Instead, something I couldn't put my finger on was off. It was a relief when a study in the Menopause Journal came out showing that I was part of the 63% of women who just don't feel like themselves, a sentiment associated with symptoms like brain fog, irritability, and fatigue. As an individual devoted to learning and having medical facts at my fingertips, it was terrifying to feel less in command of my faculties. Secretly, I wondered if this was the beginning of dementia. The symptoms were both subtle in that others would not have noticed, and devastating in their ability to cast doubt on my capabilities. I spiraled during 4 a.m. wake-ups and insidious bouts of mild yet distinct temperature dysregulation. I told no one. Instead, I did exactly what the cultural process of becoming a doctor and a mother taught me to do. I worked harder. I got up earlier, even while this limited my already compromised sleep. There is a bravado ingrained in the culture of becoming a doctor and a mother, a Kool-Aid of martyrdom. Sleep deprivation is a badge of honor, a sign of dedication. This Kool-Aid is even more intoxicating for women who are primed and rewarded for the giving to others and not the giving to self. Of course, this approach was never helpful. Now, I know these cognitive symptoms are typically transient. While perimenopause is challenging, after menopause, when the erratic hormones abate, can be liberating and a time of enhanced mental wellness. Now, I also know that there is so much we can do to help women feel like themselves again, from hormone therapy to non-hormonal medications. Medication options are one powerful piece, but only a piece of the larger story. After years of honing my caretaking skills professionally and personally, I learned that the foundation of wellness is putting on your oxygen mask first. I came to a quiet, personal, and irrefutable reckoning. My ability to help others, to achieve, to execute on my hopes and dreams requires self-care. Youth allows one to meander casually in self-care. But boy, midlife hits and meandering no longer cuts it. The bravado has wilted and withered. Self-care is not selfish. It's survival. The pillars of self-care, meaningful and mutual relationships, exercise, nutrition, sleep, and connection to others are not optional. Women are experts in caretaking, as too can men be. But for women, their identity is often premised on the caretaking of others. Putting on our oxygen masks can be a feat of reclamation. Every day in my office, I witness similar themes. Women fearful, confused, sometimes angry, and very often downplaying their symptoms. Women who need to stop mid-sentence multiple times to collect their thoughts as beads of perspiration run down their face. Women with hot flashes on the hour that steam up their glasses. Women who tell me they are no longer the mother and partner they used to be, the mother and partner they want to be. The specific symptoms may differ, but there are recurring threads. No woman escapes the dramatic rise in health risks at midlife. Suddenly, women develop diabetes at higher rates. Depression and anxiety increase by 60%. Bone density falls on average by 12%, putting us at risk of osteoporosis and notably hip fractures, which for 50% is the turning point between living independently or not. Thankfully, change is afoot. After decades of silence, stigma, and shame, we are finally starting to talk about menopause. One area which still needs greater awareness is around heart disease. Cardiovascular disease is the leading cause of death in men and women worldwide. It is an exemplar of sex-specific differences and has been sorely overlooked. So let's take a deeper dive into this slice of the health pie. Even though cardiovascular disease is the leading cause of death for both men and women, women are less likely to be diagnosed, to receive preventive care, and to be treated aggressively. Women in the throes of a cardiac event do not always present with the same symptoms as men. They don't come into the ER clutching their chest, what we see in movies and what I was taught in medical school. They often present with fatigue, indigestion, sleep disturbance, and shortness of breath. Women are over 50% more likely to die than men in the year following a heart attack, and women of color have the highest mortality rate from cardiovascular disease in the US. We know there are over a dozen risk factors specific to reproductive health that increase a woman's risk of cardiovascular disease. Just to mention a few, getting your period before the age of 12 is associated with a 15 to 30% increased risk of future cardiovascular disease. 5 or more years of infertility portends a 19% greater risk of cardiovascular disease. If you have complications of pregnancy, high blood pressure, a really small baby, a really large baby, then risk increases. As a medical student, I was taught about the risks of smoking, diabetes, and blood pressure. I was not taught about the risks of being female. It continues to astound me that as a healthcare provider in practice for 20 years, it is only recently that I learned of the multitude of sex-specific factors that directly bear on a woman's risk of dying. How did I not know this? Turns out I'm in good company in my ignorance. It's reported that only 42%, less than half of cardiologists, feel adequately prepared to assess cardiovascular disease in their female patients. These are not bad doctors. These are not uncaring doctors. The issue is that we have not valued teaching female anatomy and understanding female physiology. We do not even teach basic female body parts. A UK study found that 37% of people cannot identify the clitoris on a diagram of the vulva. I have yet to meet anyone who cannot identify man's central sexual organ, the penis. In 2019, in the United States, the National Institute of Health budget for coronary artery disease was 21 times greater for men than women. We have a compelling biomedical case for sex-specific care. Equally important, there's a clear economic argument to be made. We need healthy, productive women in the labor force. Currently, 10% of women leave the workforce in their prime in Canada due to unmanaged menopause symptoms. The Menopause Foundation of Canada, in collaboration with Sun Life, taught us that unmanaged menopause symptoms cost us $3.5 billion a year. McKinsey found that investment in women's health has the potential to boost the global economy by $1 trillion annually by 2040. Investing in women's health is not only the right thing to do for our mothers, sisters, and daughters, it is good economic policy. Women's health is an issue for all of us. Women deserve better. We can do better. I have had the great privilege of joining with brilliant, courageous women in friendship, partnership, and medicine to advance women's health. Please come together with us. Here is our call to action. Businesses, it's time to support your female employees. These are your people. Their health and your success depend on it. Our public healthcare system cannot meet every need. Step up and fund comprehensive midlife assessments for women. Doctors and aspiring doctors, insist that every medical school and residency program provide mandatory education on women's health. Women's reproductive health is a window into their broader health. It is not an extra, a nuisance, or a variable to be muted. Partners. In Canada, only one province has a billing code to cover publicly funded menopause care. Please write your local MP and demand health coverage for all women suffering with menopausal symptoms. Women, I implore you to take a snap of this slide I'm putting up right now. The next time you see your cardiologist, nurse practitioner, or family doctor, make sure they know if you have any of these risk factors for cardiovascular disease. Let them know you plan on preventing a future heart attack. Last, to the younger generation, and forgive me if this is self-evident for you, as it wasn't self-evident for me. Put your oxygen mask on early. Do not take it off. Take the time to seriously consider what fulsome health means to you. This will and should be fluid. Consider what this might look like at 15, 25, 45, and 80. Go to bed early and sleep in. Care for yourself in the same way you so generously care for others. Embrace your health and wellness. Wellness is your superpower to build equitable, meaningful relationships, to connect with community, to realize your aspirations, and to advocate for others. Thank you.
Thank you so much. Good job.